Hi, everybody. Welcome to our January 2023 Destination Health Equity Meetup. Our presenter today is Jamie, who will be telling us about racial and ethnic disparities in pain treatment in emergency medical services. So, Jamie, please feel free to share your screen.
Great, and it looks like I don't have host ability yet.
All right, let me.
If you can grant me the magical powers.
All right. You should be able to share now.
There we go. Excellent. Well, thank you all for dedicating the time. As Sonali said, there we go, and hopefully we can see this. Yeah, my name is Jamie. I'm a researcher and a paramedic. I teach at OHSU, Oregon Health and Sciences University, which is a teaching hospital in Portland, Oregon, out here on the West Coast, where I think a number of you are. All of this work that we're going to talk about it's all commingled with Lily's help. So you'll see and hopefully hear from her on some of these research pieces as well. So this is a particular piece of research that was published, I think in 2019 at this point, that got a lot of press, and it got picked up by NPR and went around the country, and lots of discussions, lots of very important discussions about the difference in the quality of treatment when somebody calls 911 for emergency medical services help. Like all good research, it doesn't happen in a vacuum. There's lots of people that contribute to it. So this particular work was sponsored by the Oregon EMS office. A lot of the data is from a private ambulance company that is the largest ambulance company in the US, and I think even in the world at this point, AMR. And then it was grant funded by the Office of Rural Health
in Oregon.
So I'm going to try to keep this 30 minutes. I am academic, so there's a lot of slides. I'm going to try to move fast. It's probably going to be 40 or 45 minutes. Hopefully it's interesting. This talk is really built for a very mainstream audience. So I'm going to start at a really high level and then narrow down quickly. So please interrupt me if you have questions. I tried to remove all the medical acronyms that may be foreign to folks so that we can all get through it together. So I think no surprise for anybody here, the advances in society and largely the advances in public health, not really medicine, but public health in general, have made the longevity of life longer, right? And this data is from the CDC from the 70s to 2007, and it continues, although there's a downturn, as I'm sure most of you have seen over the last year or so. But as we know, not everyone has the same life expectancy, right? And we look at here the differences by race and by gender. It's important to note that life expectancies are consistently going up. They're improving for all, but the disparity persists. And the disparity in lifespan as one measure of health has not improved. And arguably in some of this data, the disparity has gotten worse over time, right? So we're not getting any better at this. Now, there are a number of critics that say, really, race is just a proxy for socioeconomic status. And we also know that, unfortunately, poor people have a lower life expectancy and a lower quality of life than rich, well-resourced people. And so what people try to critique is that this is really about socioeconomic status and about race, right?
Yeah, and when Jamie says this is that some critics say that race is a proxy for socioeconomic status, I think what you mean is that the differences that we see in life longevity or other health disparities is being produced more through socioeconomic status than anything else, right? Okay, just wanted to make sure that was clear.
Thank you.
Yeah.
So if we look at one element of socioeconomic status, which is commonly the most persistent element, education, there's certainly others, and we look at, if we remove the effect of education and we look at lifespan, and in this particular data, looking at lifespan, how many years after 40 years old, You can see here, even with increasing levels of education, the lifespan between white individuals and Black individuals is different. And so pointing out that socioeconomic status as measured by education levels doesn't eliminate the disparity, it persists. So this is really not about socioeconomic status. There's something about race in particular here that we're focusing on. Of course, all of us know social determinants of health largely influence life and lifespan and health. This is not really where my focus is on research. My focus is really on the quality of health care, which is a relatively small portion of the social determinants of health. And so let's get into the disparities in health care in particular. And just as a reminder, because there's still a lot of confusion around health disparities and health care disparities. So this particular research is really focused on the differences in the quality of medical treatment that are not due to healthcare related factors, clinical needs, or patient preferences. When we look at folks that are clinically similar that go into a healthcare facility but receive a substandard of care is really where the research is focused. So there's, as probably most of you know, there's been some really large seminal studies in this space. Unequal treatment is probably the largest one that looked at the healthcare industry as a whole and found many areas of inequitable treatment across many different disciplines. And this has, of course, been replicated by a number of different organizations. AHRQ in the US has looked at this and looks at this every single year and has found that in various different medical specialties and various disciplines, some of the disparities are getting better, some of them are getting worse. So some of them that you're probably very familiar with, largely focused around African Americans in particular, being less likely to receive cardiac medications or cardiac bypass when it is appropriate. There are disparities around dialysis treatments and kidney transplants, and disparities around pain medications when African Americans visit the emergency department, regardless of the clinical similarity of their complaint or injury. So if we get even closer to emergency medical services work and starting to look at the emergency department, an area that Sonali is very familiar with, there's a number of studies that have suggested in emergency departments, there are widespread disparities. When we look at pain treatment in particular, pain treatment's a very good place to look at disparities in treatment because it is a particular treatment protocol that has a high measure of clinician
Subjectivity.
discretion. Yeah, subjectivity. So most treatment protocols around pain have words like consider, and there's a lot of work on the clinician side that they have to, they're perceived to need to believe if the pain presentation is authentic or not. And if they believe that the pain presentation is not authentic, they may withhold pain meds. And so this is a ripe area for study because it's a ripe area for bias. So there's a handful of studies here. Many of them are in support of finding evidence of racial disparities in pain treatment for similar injuries. Some of them are relatively neutral, San Francisco as an example. And these studies also span from individual emergency department studies to multi-system studies across multiple emergency departments or emergency department systems. So there's a good base of evidence in the emergency department. What's not really well known is, does this happen in EMS? Does this happen when you call 911 and an ambulance shows up and a fire crew shows up? So when I think about disparities in EMS, much like if you work at a clinic or at a hospital, I think about disparities in a few different ways for emergency medical services. One, there are certainly disparities on who calls 911 for help. We know that it is not equitably utilized as a service, regardless of the severity of the clinical condition or the injury. There's lots of reasons for that. The second is when EMS is called, what does the quality of the care look like on scene? And then the third is the diverse workforce issues. Is there diversity? Is there equity in who gets hired, who gets promoted, who's in the leadership positions at these organizations? So this particular research is just focused on this middle one, focused on the quality of healthcare when EMS is called. So I just don't want to give the impression that this is the only area of equity in EMS or inequity in EMS. So there are two existing studies before I started to look at this. One is in 2009 in Contra Costa County, which is Oakland, California area. And they looked at patients that were called for a head injury, a headache, respiratory failure, or a suspected they excluded those folks and focused just on blunt trauma cases. So if you called 911 for a blunt trauma like hit with a bat, got in a fight with somebody else, altercations, who was likely to receive pain scores. And you can see here, Black patients, 45% less likely to receive pain medications for blunt trauma. And they were 85% less likely to receive them if they did not collect a pain score. Second study that was published is more of a descriptive study using 2012 and 2014 data, looked at about 66,000 different medical charts and found that all racial minority categories were less likely to receive pain medications, in particular for fractures, burns, and penetrating trauma. And again, this was just a descriptive study, but it was across data from the entire country of EMS providers. But again, there were no controls for socioeconomic status. So it was very difficult for them to say that this is about race or racism when it very well could have been socioeconomic status. So then I started to get curious to see if this happens in Oregon. And so this was the study that I did looking at data within Oregon, looking at about 100,000 medical charts from 2015 to 2017. And that number of charts represents about 85% of all EMS agencies in Oregon. One of the downsides of decentralized medicine, and in particular in EMS, is there are something like, I think at last count, something like 330 different EMS agencies in the state of Oregon. They all have different treatment protocols. They all have potentially different medical directors. So there is no standardization that's very well controlled for. Yeah.
And I just want to point out, we've missed a couple of abbreviations here. So I just want to point out some of the abbreviations in this slide. So EMS is Emergency Medical Services. We've been saying that for a while. But PCRs are Patient Chart Record. Patient Care Record. I don't even know what our abbreviations are. Patient Care Record. And then ALS is Advanced Life Support. Or advanced life support. Yeah. Jeez, I'm doubting myself. Okay, back to the corner.
So I was only interested in adults with traumatic injuries or complaints of pain, and I excluded cases of respiratory distress and altered mental status because these are largely contraindications to providing pain medications. So if somebody is having difficulty breathing, they often can't give them pain meds because that's a respiratory depressant. So I wanted to remove all of the ineligible patients from this study that were ineligible to receive pain meds so that I could look at everybody that was eligible and then determine who received a pain screening is the first question and who received pain medication for the second question.
And a pain screening is the typical, like, how, scale of 1 to 10, how much pain are you in? And when we say who receives a pain assessment, we mean who did they even ask? Are you in pain, scale of 1 to 10? If they did, then we consider that they have had their pain assessed.
So I'm happy to go into the details of the research, but I'm jumping to the punchline here. So stop me if you have questions on the nitty-gritty and the statistics. So first, one of the highlights when we just look at pain assessment, and again, as Lily said, just who received a pain screening or not, and that's as simple as what's your pain score, 0 to 10. So when we look at models that adjust for differences in gender, differences in patient age squared, which I can explain, patient health insurance status as a proxy for socioeconomic status, the anatomical location of the injury or pain. So we're taking in the difference between a broken leg and a broken fingernail. The EMS provider's specific primary impression. So this primary impression is really the diagnosis from the paramedic on scene about what the injury is. So when we control for all of these things, and we just look at the variation by patient race, and when we compare it to white patients, we can start to see some really meaningful differences here in that Hispanic patients and Asian patients were much less likely to even receive a pain assessment in the situation of a traumatic injury, right? When we look at pain medication administration, and again, this is a dichotomous or a binary variable, we're not asking about what type of pain medication or the dosage. We're just asking, do they receive any or nothing? We can start to see some large disparities compared to white patients here with the same controls, that African Americans are almost 30% less likely than white patients with the same conditions to receive pain medications. You can see the difference from Hispanics and Asians here as well. So at this point, I've published this study now, and agencies are furious and providers are calling me and saying that we think they're racists. And why would I do such a thing to taint our industry? We're heroes after all. And so AMR, which is obviously the largest ambulance company in the state and provides ambulance services for all of Portland Metro, approached me and said, I want to know if this happens in Portland, because in Portland, we're special snowflakes. And, you know, crazy things happen on the other side of the state, much like Washington. The east side and the west side are very different. So we're kind of special here. And so can you help us determine if this happens in Portland? So if you haven't seen this, this is a very real person in Portland in a Darth Vader suit on a unicycle with flaming bagpipes. It's pretty impressive. So at AMR then did basically the equivalent study, very similar controls, similar research questions to know if, to see if this happens in EMS.
In the Portland metro area.
Yep, in Portland Metro. And it's really in Multnomah County, which includes the metro area, and then it goes out east into the suburbs quite a bit as well. So and jump into the punchline here again. There were 2 counties, and I've presented this with them, and so they have no qualms about this being public information. County A is Multnomah County, and County B is Clackamas County, which is the county just south of us. And so here we can see the differences in pain assessment, which are largely bigger than the differences or the disparities in the pain assessment when compared to the rest of the state. When we look at pain medication disparities, we can also see some large differences for patients that have almost identical complaints and just asking who receives pain meds or who doesn't, so the dichotomous variable. And this includes all pain scores. And some providers may say, well, all pain scores is kind of irrelevant because I don't give pain meds to people who have a pain score of 2 or 3. We argue they still should. So we look at also severe pain scores. So the people that complain of a pain score of 7 to 10, who receives pain meds and who doesn't. And interestingly, as you can see here, African American as example, the disparity gets larger for patients who are in severe pain. So this starts to beg a bigger question. And if we only focus on pain medication administration, we might think that there's something interesting only about pain management in EMS. But this is not, as we know here, this is not about pain management. We're using pain management as a way to see racial disparities. And in fact, this is about race. This is not about opioids. This is not about the opioid crisis. This is about treating people differently, and more specifically, treating racial minorities with a substandard of care versus white patients. So AMR wanted to look at other call types and to see what other medical conditions might we find evidence of substandard treatment. So if you're not familiar with intubating, so intubating is just basically putting a breathing tube down somebody's throat to help them breathe when they're in respiratory distress for a variety of reasons. It's something that happens in the operating room. It's something that happens in the emergency department. And it also happens pre-hospitally, on scene, out in the field. It's a standard practice for EMS providers. And so because of that, and it's a very high impact, low frequency procedure. So there's lots of preparation steps, there's lots of protocols around it, and lots of standard of care treatment around it. In Oregon and in Multnomah County, this can happen without a physician involvement whatsoever. It's the decision and the discretion of the paramedic on scene. When we looked at minorities, and if they were as likely to receive all the preparation steps. And here, that is a matter of having a cardiac monitor or a 3-lead, having IV or IO access so you can provide medications, having an SpO2 monitor so you can monitor the oxygenation levels, and then also pre-oxygenating the patient before this procedure so that your intubation procedure is much more likely to be successful on your first attempt. And we found all racial minorities were less likely to receive this package of preparation steps. So they were approached with this procedure under much more risky situations. Now, also in Multnomah County, in Portland here, there are 2 protocols when you intubate somebody that are available to medical providers. One protocol, and these are for all people who are alive. These are not for cardiac arrest patients, which has a different procedure. But if you're alive and you need to be intubated, you can choose from one of 2 options.
Paramedic can choose.
Paramedic can choose from one of 2 options. One is you can use medication-assisted intubation, which essentially puts you to sleep and paralyzes you. And the evidence behind that process, just like you would go through in the operating room, is it's much more successful intubating those patients than if you do not do medication-assisted intubation. And so for a variety of reasons, some known, some unknown, the medical director in Multnomah County has decided to have both procedures available to paramedics. And so paramedics could choose to intubate somebody who's alive without medications or choose to intubate somebody who's alive with medications. And so we were curious, is there inequities on how people get intubated? And so you can see here the second bullet point that Black patients, very concerningly, very interestingly, were 73% more likely or less likely to receive medication assistance in their intubation procedure, meaning they were intubated without any medications to assist with the process. We looked at chest pain calls. This is a very common call, and looked at a variety of measures of the standard of care. We found all racial minorities were less likely to receive a 12-lead, which is a more thorough diagnostic procedure done in the field to determine if a patient is having a heart attack. So all racial minorities were less likely to receive it in the required time frame of less than 10 minutes upon arrival. Black patients were 43% less likely to receive 2 full sets of vitals, which is a standard of care that's dictated by protocol. And then you can see Asian patients were also much less likely to receive a full advanced cardiac treatment.
Kick that person out.
We gotta kick this person out. We've been,
Sonali,
can you see that?
You gotta get that person out. I'm sorry, everybody.
Looks like she got him.
Okay.
I'm not one of them.
Sorry.
Sorry, I'm not able to see the,
There we go. I think I got them.
okay. Or, to me, I'm still seeing the both of you, so I'm not able to see the Zoom bomber.
Okay.
Okay, I think removed them.
Awesome, thank you.
Yeah. All right, and then the last medical condition that we looked at was stroke. And we did not find any differences in the treatment of stroke in EMS. Now, stroke is an interesting one because there's not a whole lot that can be done by field providers. And so it's largely supportive care, and it's largely care that is in preparation for more advanced care in the hospital. So it's things like making sure you have appropriate IV or IO access so that you can get a patient very quickly into a CAT scan situation to determine what kind of stroke, and then to determine appropriate care from there.
So Jamie, there is a question in chat.
Oh, good.
Kate comments that it would be interesting to see if the percentages change simply by letting the paramedics know about the data.
Yeah.
Yes. So you're absolutely right. We feel the same way. We feel, and the assumption I think that we have is that providers don't know this is happening, and providers don't want to be this kind of provider, but they were never presented with the data to suggest that this might be happening, and because it might very well be subconscious on how they evaluate patients, how they determine who's in pain, etc. And so we have, the agencies that we work with, we certainly have suggested that take place. Agencies have been resistant so far to do that, and they have decided in lieu of that to try to recommend system-wide trainings on subconscious bias as a way to see if it can help. I think it's too passive. I think we've got the data to determine in particular which providers are really terrible at this, which are doing great. And so we certainly need training across the full system, but we've got a lot of data to say who needs more help to get better, not in a punitive way, but with the assumption that this is not the kind of provider they'd like to be. So let's help them more specifically. So, and I see that Sam has a question.
Yeah, hi everybody. I'm joining from Texas, which has its own issues. And as somebody who's lived here for more than 3 decades, and the few times that I've been pulled over, the police, they have these, the ethnic markers that they have to do. And going back to the 90s, they regularly check people off as white. Even if nobody else in the world would consider them, just to make the numbers look better. And so I'm just wondering, like, if basically if people are basically mandated that they have to track these things, might there be some such behavior, or are people basically aware of such a possibility? Thanks.
Yeah, it's a great question, Sam, and thank you for bringing it up. So a couple of things related to your question. One is what we're dealing with here is the charted race of the patient, which we believe the vast majority of time is the perception by the medical provider of what their race is. And it's indicated without a consult with the patient. That's yet to be verified, but that is very likely what takes place. Now, we think that is probably the most important characteristic when we're looking at race, because it's this perception that likely influences the provider's behavior, which may be different than how the patient self-identifies. The second part of your question, which is also good, this particular agency did not require race to be collected. on patient charts, which is interesting because they bill Medicare and Medicaid, which requires race data in order to be reimbursed. But even though it wasn't required, about 80% of the charts had race charted in something other than unknown. So most people did not, we feel like most people did not at least erroneously choose white. They chose what they thought their preference was.
However, since this study got a lot of attention in national and local media, we have seen that since then, the proportion of charts without any race data indicated has increased, while the rate of recording gender-related data has stayed the same.
Right. So when we could look at providers charting behavior before the study came out and after, many providers chose to now just chart race as other, when before they were charting race in a much more distributed, diversified manner. That is to be said, there's also been other providers that have charting race more comprehensively now after this study got a lot of press.
And to Sam's point, I think there are probably folks just messing with the data in general. I mean, I think you're absolutely right. There's definitely going to be some acts of rebellion through charting, and we've talked with agencies about ways to learn more about that, potentially by both asking the provider to indicate race data and by having a separate process for patients to indicate their own identification of race, gender, and other demographic data.
Yeah, sounds like a good idea to keep track, but you know, a thought just occurred to me that maybe if whoever is, you know, tagged one way or the other, maybe they can get an email later saying that, hey, this is how you have been classified. If you have a problem with that, click on this link.
Yeah. And our hope, this is the exception, especially in this kind of aggregate public health level reporting and analysis, when we're looking at 100,000 records, that kind of hopefully actively erroneous reporting gets washed out.
Or addressed directly through performance evaluations and things like that. We're certainly making a lot of recommendations in that direction as well.
Yeah. Sonali, did you have a comment? And then I want to get to Jennifer.
Yes, no, I did just want to point out that Jennifer has a comment.
Yeah, very good. Thank you. Jennifer.
Hi, this is Jennifer. I had a question about Care Everywhere. Does your local hospital use Care Everywhere?
Can you describe what it does? I think there's
it's basically a program where the patient's records are shared across different organizations. So if the race is collected in one facility as one thing, then it should match up with the other one. And then there should be ways, in my opinion, that the hospital will be penalized dollar-wise if things are not matching up, or if there's a whole bunch of people that the race and sexual orientation and stuff like that is excluded. I think you have to slap their hands money-wise. That's usually the way that people take notice. And then maybe some training, hiring more diverse staff as well is another way to address that. Numerous times where people complain about pain and it gets documented that they're experiencing pain and this, thus, and so. And then they'll make documents that the person seemed depressed. Of course they seem depressed. The pain is getting worse and nobody's dealing with it.
Absolutely. All good points. The EMS agencies, to my knowledge, still don't have access to the kind of shared charting that you're describing. I do believe that is happening amongst the different healthcare systems within Portland, especially when it comes to trying to identify opioid-seeking behaviors, where people will shop hospitals looking for opioids. They tend to be very focused on sharing information then. But the EMS agencies often don't, there's not a dialogue between a hospital chart and an EMS chart like there should be. There's often a one-way street where the EMS chart gets pushed into the hospital chart. That is starting to change so that there can be more reporting like what you've described. There have been some published studies that have looked at race concordance between EMS charts and hospital charts, and overall, they're pretty well matched. But I agree with you, having some two-way communication between the data so that performance data can come back to the EMS provider around the accuracy of not only patient demographics, but medical diagnosis, treatment effectiveness, treatment appropriateness, et cetera, is where we're headed. Just many systems are not quite there yet.
I want to echo what you just said, Jamie, because after talking to EMS people also in Washington, so Jennifer, I'm aware of what Care Everywhere is. It's the EPIC communication between different healthcare centers, but also in Washington, my understanding is that the EMS people do not have access to patient charts from sources like EPIC.
That's true, yep.
We have some agencies that have expressed interest in being a part of a pilot program in the Portland area to try to see how that might work in Oregon. We're very excited about that and are trying to make it happen. But those are long processes, but hopefully soon.
Yeah, hospitals are not super happy and have for years fallen back on a fallacy that there's HIPAA violations in sharing patient data with other healthcare providers, especially for a QA effort, which is
quality improvement, quality assurance.
Yeah, which is just not accurate. And so they're slowly seeing that and seeing the benefits of sharing data with EMS in both directions. So finally, in this talk, we felt like we needed to spend time on mechanisms, because as we talk to EMS providers, they all say, well, why is this happening? They kind of quickly jump from, thanks for describing the severity of treatment disparities, but why is this taking place, so that we can move to hopefully get to a place of mitigating or doing some interventions. And so this is, as of a couple years ago, I think our summation of why this is likely taking place in the EMS context, some of the major theories behind why this action happens. So first, as you're probably all thinking, language barriers causes a big part of this. If you're unable to speak English, or the scientific term is limited English proficiency, or LEP patients, it's really hard to receive high quality care. And unfortunately, patients who are LEP are also very much more likely to be racial minority patients. They're also much more likely to be poor patients. So that's a very vulnerable patient population if you cannot hold a conversation with them. I think I've got a couple slides here. Oh no. So if we, what's frustrating at this agency that we looked at is there's a lot of agency contributions here. So most of the problem is not that we've got racist providers or we have broken providers. Most of the problem is the system doesn't support them providing equitable care. Language barriers is a great example of that. There's no training for paramedics in Portland on how to interact with a patient they're unable to communicate with because of a foreign language. There's no expectations, there's very few tools, and so providers are left to their own devices to do whatever they think's best. And when we looked at the data, about half of these patients, it was simply put them in the back of the ambulance and drive with a note in the chart saying, I'm unable to speak with this patient, and there's an interpreter at the hospital. Now, every single ambulance has a cell phone with a speed dial number to a language interpreter line, but there's no enforcement or reporting from the system side to say how well those patients are taken care of. So this sends a very clear signal to the field providers that this is not an important population for us, and we're not really paying attention to it. And so this is one of the, I think, mechanisms behind some of the disparities for some of the racial minority patients, but certainly not all of them.
I'm also going to interject
Yeah.
and say that I have a slightly different opinion than Jamie on this. I do think that what I agree that there are distinct moments where the systems are contributing significantly to these disparities, but I also believe that racial bias is on an individual level is a big contributor to the data that we are seeing. So
yeah,
I
agree. It's not exclusive. It's not exclusive. There's multiple contributors.
We do have racist providers.
Yes.
Yeah. And we do have racist thoughts that are influencing providers as they provide treatment.
So a second mechanism is this belief that race is a biological construct and not a social one. Mm-hmm. There's unfortunately still today evidence that medical providers believe people of different races are physiologically different. Things that have been proven false over and over again. But there's a great study by Hughes that looked at perceptions by medical students, first year and second year students, of proven false biological differences, like African Americans, black skin is thicker, their blood coagulates faster, bigger muscle mass, etc. And a very large concerning proportion of medical students believe that these things are true. And so if you have this belief that race is a biological, important, relevant construct to medical treatment, then you can easily rationalize in your head, justify differences in treatment.
There's even, for folks who haven't spent a lot of time in the back of an ambulance, there's devices in an ambulance that often will have different settings based on race. So they will have, it's surreal.
In the hospital as well.
In the hospital as well.
Ventilators in the hospital, calculating kidney GFR filtration rates has race adjustments in them. The pulse oximeter was discovered that they are less sensitive for dark color skin with melatonin, right? These things that are just getting discovered, and we're still not making adjustments to how we practice based on those. Down on the street level.
Yeah.
The third, sorry. Oh,
yeah, there's a question from Jennifer. Do they still teach African Americans can tolerate greater levels of pain?
You know, it's interesting. So there's a philosophy that probably many of you are familiar with in medical training in a medical school of a explicit curriculum and a hidden curriculum. And explicitly, that is certainly not taught, not believed to be taught, but the hidden curriculum that's not written down, that gets communicated between an attending and a resident, or an attending and a medical student at the bedside, that's shown through that attending's behavior, is where these things are believed to largely be established and fester.
Thank you. And I'm also curious about those actual instruments with settings for race. So if there are no evidence-based foundation for these kind of settings, why do companies make that, and how is it, even legal, if not
Yeah, Sonali, it's terrifying. If you've not read Medical Apartheid, it's a great book. That's a primer on this. Can send you a link on it. The history of medicine was born out of very racist practices, and through experiments on slaves, and a lot of those learnings and ideals are still with us today, unfortunately. So there is a lot of bad science that suggests that these physiological differences are real and are true, but have been disproven by other good science. And it's still, the system hasn't changed to fix all of the things. Yeah, so if you go into your hospital and you go talk to respiratory therapy and you talk about ventilator race settings, I'm sure they will be happy to talk to you about them. And hopefully they tell you, yeah, that was a thing and we've changed it.
But I mean, when I get my blood tests, when I visit my doctor, I get readouts that say, if you are Black, this is the normal range. And if you're not Black, this is the normal range. And those are, I mean,
Absurd.
It's absurd. And
Yeah.
it still happens today. It's an important thing that I engage my doctors on it all the time. They're probably irritated with me bringing it up all the time, but it's true.
Yeah. And thank you, Kate. If you need to go at 8, totally understand. Thank you for being here. So this is just some brief data on that study that I mentioned about medical school students, first year and second year. And I'll just cruise through this so you get a sense. This is the percentage of medical students that said, yes, we believe that this is true. And again, these are all proven false, right? But we've got first year and second year medical students believing a lot of really difficult things that you could see how they might rationalize disparities in care.
Yeah, really dangerous.
Yeah. The third mechanism, I think, is a theory of cognitive load. And largely, excuse me, this just suggests that when we need to make decisions under heavy cognitive load, due to time pressure, due to ambiguous information, due to other outside constraints, which happens a lot when you practice medicine outside of the hospital. And it also happens when you practice inside of the hospital. You're more likely to use stereotypes, and those stereotypes are very laden with bias. And so in those situations, we're likely to see more treatment disparities. So it doesn't mean stop using stereotypes, and the practice is largely to recognize those stereotypes, have bundles of advice and thoughts behind them. Things like young African-American males are dangerous, right? That's not true, but if you formed your impression from a stereotype by watching The Wire, one of the greatest TV shows ever made, by the way, you might think, and you don't have any African Americans in your circle, you may think the media's representation of that person is true for everybody. And so it forms your stereotype. And then the final mechanism is aversive racism. So racism, race scholars talk about, this is the third major phase of racism. We went through chattel racism of slavery, the first phase. Second phase, Jim Crow area of state-sponsored racism in the US. And now we're in the third phase called aversive racism. And this is really where unconscious bias comes in. This is people that are outwardly, explicitly all about equity and saying that they are not racist, but may, when they're in the back of the ambulance or sitting in their exam room, may feel uncomfortable with people that are different than them. And so that may influence their behavior on how they end up treating patients. And I think just some summary, which we don't need to go over. But importantly, I think this third bullet point is really important to talk about, that this doesn't mean people are broken. This doesn't mean providers are broken. It means that they're human, just like any other medical professional. So there's lots of areas that we talked about where there's disparities in care, and it just hasn't been explored in EMS. And so since there's humans working in EMS, of course, there are going to be disparities, and racism is going to have an influence in EMS, just like sexism and ableism and ageism is going to have an influence. And so this work really just served to highlight, is it present? How big is it present? And hopefully start to understand how it operates.
Yeah, and I would add that our culture is broken. EMS providers operate in that culture. But EMS providers are also interested in my experience, in learning about the ways in which they can improve their care. And so a lot of the work that Jamie and I do we attempt to draw the connection between, you know, if somebody told you that you were providing a type of treatment that was actually harming some of your patients, would you want to know? And they always say yes. Race and racism and racial bias is an emotionally charged area for all of us, and so it is more complicated and it's tougher and it's still harming patients. And so that is the work that Jamie and I do, and that's been our approach with our clients.
Thank you for sitting through.
How do we do?
Thank you so very much, Jamie and Lily. This was very, very informative and a lot of nuanced pieces to this. I'm going to stop the recording now. Please feel free to join us on meetups if you are watching this on YouTube, and we'll continue with our discussion.